Good day, everybody. I hope you are gone through all my previous lessons. If you have not gone through, just subscribe to my playlist. The playlist is button is above over there. Okay, so you can playlist. And today I'll be talking about bladder cancers. Very short. Okay, this is basically for medical students, and I'll be covering on superficial bladder cancers and muscle invasive bladder cancers. The same book. I will like to keep my lecture today in a case-based fashion. Okay, so you see, get a case, discuss about the case, what will be the treatment options, and then I will take another case. Okay, like this. So let me share the screen. Okay, so this is the carcinoma bladder case discussion I was just talking about, and we have this first lady with us, who is a 65-year-old lady, and is just presented with lower tract symptoms. So from the face value of this history, you can well jolly understand that you are dealing with a UTI case, a lower tract infection, urinary tract infection due to with lower tract symptoms. Okay, so she's not having any fever, vomiting, all these negative histories. You don't take any addiction history. You take an addiction history also, and she doesn't give any history of addiction. Why? Because what are the factors predisposing to superficial bladder cancer? Smoking, especially in slow hepatic acidity, it is 3 times more common. Okay, these tumors, industrial carcinogens like anilines and naphthols, basically in paint industries. Okay, and then we have phenacetin and cyclophosphamide, are the drugs causing superficial bladder cancers, and some chromosomal abnormalities, most common being chromosome number 9. Okay, now you see a general examination. You do the general examination, you see nothing very contributory, and you go to the investigation to see this RBC in plenty. Now this is very important. The patient has WBC in plenty, the patient has RBC in plenty, and the urine culture has no growth. Albumin trace may be due to the patient because she has been diagnosed with, now she has diagnosed with high blood sugars. Okay, now what I want to talk about is RBC in plenty means she doesn't have any visible hematuria. So she is having a significant microscopic hematuria. How are going to quantify microscopic hematuria as significant or not? So it all depends upon the unspun sediment. So there's something called the unspun sediment, that is the urine sample. You see it under the chamber Coulter counter of a microscope, and you see this more than 3 RBCs or hyperfilled, you call it a significant hematuria, microscopic hematuria. Or if you are basically there are labs who are doing this centrifuging the samples and letting off this supernatant, taking this pellet, the it's considered RBCs, and then they resuspending into a saline solution, then again the seeing it on the Coulter counter. In that case, basically the definition becomes different, becomes more than 5 RBCs per hyperfilled in a spun sediment or a sediment. That's the normal term being used. So the other way around of detecting microscopic hematuria is dipstick examination. And I can tell you, dipstick examination is it's very sensitive to bias, because all this peroxide, anything with a peroxidase activity like myoglobinuria or any other enzymes, if they're present in the urine, they can basically give it a false positive. Okay, and also the quantification, if you have to quantify it, you keep it, you put in a dye, put it a stick into the urine, take it out, see the color change, and measure it on the chamber which has been given on the side of the stick, the bottles having the stick. So it may say it's 1+, it can say 2+, it can 3+, depending on the color change. Okay, depends upon if you have more than 10 RBCs, more than 50 RBCs, more than 100 RBCs, all these plus signs it signifies. Okay, now this is the next step, obviously, because you're dealing with a person having microscopic hematuria significant, culture is negative, and the patient is having lower tract symptoms. Though your first differential diagnosis comes in your mind is basically a UTI, but you must also understand the patient can have the stone symptoms and can have malignancy also, because all this carcinoma in situ. Okay, all these flat tumors are very liable. They don't cause much hematuria, but they cause all these lower tract symptoms, especially common in elderly females. and especially common who take this all this kinase and snuffs, tobaccos, and all this. Even berries, elderly females smoking berries are quite common nowadays. Okay, all this low, the low socioeconomic. Now you see the kidneys are not very well. It's all fuzzy picture, but they appear normal. But you can see on the bladder picture, you'll see a space occupied lesion involved in the bladder, and you ask the ultrasounders are doing the ultrasound, just compress upon it whether the elasticity pattern of the mucosa overlying or underlying this tumor is totally lost. It's totally lost. You can switch on your of this Doppler settings if you have this in your machine, and you see this lot of vascularity. So all this suggested is not a clot, not a fungal ball, nothing else but a blood tumor. So the next step, you do a CT scan in this case, and you see CT scan of the KUB and the pelvis, and you see there is a this contrast enhancing mass in the bladder, and it appears there's a loss of the fat planes on the side of the bladder tumor. That's very much suggestive from muscle invasive pattern from the CT scan per se. Now, the next step, obviously, you have to counsel the patient about the prognosis, about the diagnosis. The diagnosis have changed rampantly from a UTI to a bladder tumor. What is the prognosis of the tumor, and what is the next step you're going to do? You take her to surgery, obviously. So you have to counsel her that you need to have a proper bladder biopsy. For this, you have to do a TURBT, cystoscopy, a TURBT, an examination under anesthesia, under GE, and in the OT, and the OT settings after proper consent. You take a proper consent of the patient. Okay. So this is a TNM staging. So obviously I said if it's bladder is an epithelium, so anything from the epithelium becomes a so superficial bladder tumor. Whenever it involves the bladder muscle, the tissue, it becomes a muscle invasive bladder tumor. And anything it grows, it becomes a locally advanced bladder tumor. Okay. So this is a risk stratification of superficial bladder cancer. You have a low risk, which is basically, again, you have to, because whenever you have to excise a tumor transurethally, you send it for the pathological analysis. You also ask the pathologist to talk about the grading. It all depends upon the nuclear size, the nucleolus number, and the pleomorphism of the nucleus, the mitotic figures, number of mitotic figures. So the grade 1, grade 2, grade 3, again, on depending upon the tumor size, whether solitary or multiple or recurrent, whether the carcinoma in situ is present. Okay, even carcinoma in situ, high rate of having a metastasis, even though it is looks apparently superficial bladder tumor. Okay, because it doesn't involve the blood muscle. Okay, but they have high rates of basically going to metastasis stage. So this is the cystoscopy we normally do. You see the tumor site of the tumor, any additional sites are present or not, and then we put in the resectoscope and we take out the tumor under general anesthesia. It's very important to understand why general anesthesia, we use spinal anesthesia. What is the difficulty? The difficulty is this: the tumors are often located in the lateral wall. Mostly these are on the lateral wall, and just beside it we have the obturated nerve. The obturated nerve are basically supplying the adductor muscles of the legs. So whenever you're cutting by diathermic current, some of the current may leak through the bladder. I mean, these are very common because the soft tissue just irritate these nerves, and the nerves and the legs go into spasm, adductor spasm, and basically you will have what is known as the bladder rupture. Because sudden jerk of the bladder caused by this adductor spasm will cause bladder rupture. Okay, you inadvertently make a small, tiny piece of rupture in the bladder mucosa, and through it you can see fat coming into the muscles. I will show you a picture, and we see the water. Basically, you use glycine. You're using glycine, and the glycine pushes out from inside the bladder out into the retroperineum. You have the fat belly, put in all these drains and all these things. Okay. Now, this is I said the risk patterns and observation. Most of these intermediate risk groups, they will need to have BCG installation, because to prevent recurrence, that is, a superficial bladder cancer becomes a superficial bladder cancer in the future. Progression of superficial bladder cancer becomes a muscle invasive bladder cancer in the future, or metastasis. All these things, for this is to not to occur in the future, you give BCG installation via the bladder. Okay, if the patient is not very happy with the BCG, because these BCGs are very toxic agents, so they have cystitis, vesicosis, tuberculosis like symptoms, all these things. Even when the guidelines are followed, then what really happens is that you have to go for mitomycin. It's not as effective, but okay, do. So why do you do cystectomy non-muscle invasive tumors for CIS tumors? And even if they are BCG failures, they are still on BCG maintenance. Induction is you start giving BCG weekly to 6 weeks. You can do 80 milligram, you can do 120 milligram. Even people are saying 27 milligram is also very good. Whatever, normally a protocol was 80 or 120. Weekly into 6 weeks on a particular date. We start at least 3 weeks after TURBT. Okay, then we do a check cystoscopy. Okay, now this is the induction BCG. But Maintenance BCG is every 3 months, 3 weeks, weekly into 3 weeks. Then follow it up by 6 months, weekly to 3 weeks, then 6 monthly. That's the maintenance BCG. But still on maintenance BCG, the patient recurs. Obviously, we will think of doing a cystectomy in a non-muscle invasive bladder tumor. There's no role of radiotherapy. These are the few representative pictures. These are basically superficial bladder tumors. I think these are large tumors. Basically, they are not fronded. These are not fronded tumors, calcified tumors, and tumors within the bladder diverticulum. They are very likely to be muscle invasive. Okay, take a punch biopsies and you see this is you have taken also sensible section from the muscle coat also, because whether to know whether there's a muscle involvement or not. Small fronded tumors doesn't have any muscle involvement, but these large flat tumors more than 3 centimeters. I talked about the prognostic criteria. These have muscle involvement and they become muscle involvement. The whole prognosis is changed. They become candidates for radical cystectomies, radical radiotherapy, and all these things. Okay, this is how you take out the bladder tumor by loops, and this is how the scar looks like after maybe after 3 weeks or 4 weeks. Okay. Now, this is the next case. We are dealing with a metastatic, sorry, not a metastatic, but a muscle invasive bladder tumor. It's a chronic smoker with a lot of comorbidity, painless, gross hematuria. We do a flexible cystoscopy early and saw 5 centimeters sessile growth. So it's not a fronted. It's something called a fronted and sessile. Just let me stop this here. Tell you, go to my this thing. I will tell you what is a fronted tumor, and this is the fronted tumor. What is it? A cauliflower tumor with a stalk. It's more likely to be non-muscle invasive. But a tumor on a broad base without a stalk becomes a muscle invasive. This is the rule of the thumb. So it can change. The most of these cases are basically these things are basically non-muscle invasive tumor, but the muscle invasive as well. Okay, so that's it. So we did a upper tract is normal. We did a TURBT with high grade muscle involvement tumor. What are the our treatment options in this case? Obviously, you have radical cystectomy, radiotherapy, or chemotherapy. What is radical cystectomy? Radical cystectomy is you remove the portion in the bladder. In a female, you use the bladder with the anti-exantesh. Part of the anti-upper third of the vagina is also removed, plus the lymph nodes and the lower end of the ureters. So what are the methods of urine diversion? Previously, we had to use ureterocutaneostomies, where the ureters are basically implanted in the skin as small cutaneous pouches. It becomes a hell of a job for the patient. Next, the most commonly still used today in most of these centers today is the ileal conduit. This has withstood the test of the time, where you take a ileal loop, you basically make a resection anastomosis to the rest part, the resected segment, take it out as the ileal loop, and implant the ureters in the one of the end, and the other end comes out as a cutaneous pouch, cutaneous stoma. Okay, but these patients doesn't have a continuous mechanism. They have to put in a bag always. But if it used in a pouch fashion, and implicate some part of the distal end of this mucosa inside, so it creates a sort of valve action. So the patient now goes to the loop, put in a self catheter, and drains out the urine. So his continent to the rest part becomes, so he doesn't have to carry a bag, becomes a continent ileostomy. But nowadays, the most important thing is orthotopic neobladder, where you create a Studer pouch from the ileal segment, and you basically, because the urethra is normally free of tumor, because the tumor is away from the urethra, the prostate urethra, we take 7 biopsies also, and doesn't show in tumor. So you anastomize the urethra, and basically the patient is likely to have the same continuous mechanism, same way he passes to urine before the cystectomy. Now he's having a orthotopic neobladder. Okay. Problem is that it does that. This is a not a natural bladder. Though you use natural sources, the ileum, but it doesn't work like a bladder like way. It will take some time to behave like a bladder. So there will be a lot of mucus generation which needs to be washed out. All this nerves, all this continuous mechanism will also be delayed in the early part. Okay. Now, this is the lymphadenectomy. This is the template for a standard lymphadenectomy, the pelvic lymphadenectomy. Very important for lymphadenectomy point of view is that you have to, lymphadenectomy is not only prognostic criteria, doesn't show, but it's also about having curative role also. So you're also having a curative, you increase the overall survival, especially if you do a lot of lymph node sampling, and sending it for biopsy. But this has been put into some amount of controversy by the recent literature. But again, you can say that it has a curative aspect as a prognostic aspect also. So key concept is the number of lymph node removed, the number of lymph node metastasis, and lymph node density also. Now, so I'll finish off today's topic with the bladder preservation strategies, where you can use a partial cystectomy, but you have to combine it with chemoradiotherapy. Yeah? Also TURBT, radical is called the radical TURBT, where you also put in the component of chemotherapy and radiotherapy also. So if you have any questions on this bladder tumor, because I tried to make it concise and just put it in a short bite-sized video, so you can see this as a video. So just as a refresher course, or if you want to go through the big textbooks, just have an idea. So if any question, just feel free to comment in the comment section. And in the meantime, if you're not subscribed to my channel, just hit the like button and also subscribe my channel. So you get a lot of these medical videos for easily listening and easy trying to go through the for just before the exams. Okay, and also just there's a playlist also for this medical video. Just hit the playlist also. So bye bye. I will be coming again with another lecture in soon. Okay, bye.